I know everyone's incredibly busy. Thanks, Katie. So very, very excited to go through this conversation today. The goal is really to have this be more of a conversation than a presentation. So if you're expecting a bunch of boring slides, you're probably not going to get them. But I want to take full advantage of the two experts we have on the phone today. A little bit of housekeeping type of stuff. I always have to start with that, as you might have heard. This webinar is being recorded, so need to make sure that you are aware of that, so that if there's any issues with that, feel free to drop off now. And then additionally, as you probably all know, or if have attended these before, you guys are all muted at this point. If you have any questions, comments, there's already been a few flying in the chat. Please feel free to put those into the chat, and we definitely want to leave some time at the end to make sure that we answer your questions as well. So my name is Dan Shields. I serve as the CEO for digital medicine at Ochsner Health. I've been in that role now for my role for about 3 years. With me, I have a couple of experts that I'm hoping are going to do the vast majority of the talking today. First, Dr. Kenny Cole. If I know many of you on the line have heard Kenny speak before. Kenny is our System VP for Clinical Improvement at Ochsner Health. He is a practicing primary care internist, still sees patients at least 1 day a week, and is a bit of a zealot towards quality and towards improving outcomes. I hope that comes through. He has several degrees from LSU, from Dartmouth, executive training at Harvard. His focus is really on designing and implementing the buzzwords are multidisciplinary team, basically a team-based model of care, focusing on primary care, with the goal being to align outcomes with financial outcomes, which is obviously something we feel that the systems need to move towards, and as what we think is a forward-thinking health system, something we focus on pretty heavily. This actually can be seen at work in what we call our 65 plus clinics, which is actually a series of advanced primary care clinics that Kenny has stood up, but also bringing that to his work as our medical director for digital medicine and connected health as well, where we focus on using digital technologies to drive outcomes predominantly across chronic conditions at this point. So that is Dr. Kenny Cole. For those of you that don't know, Dr. Bricker. Dr. Bricker is also an internal medicine physician, former co-founder and chief medical officer of Compass Professional Health Services, an organization I knew pretty well in my past life. Compass was a healthcare navigation service. Grew to over 1.8 million members across 2,000 clients. Notable names would be T-Mobile, Southwest, Chili's, and Maggiano's. As many of you know, Compass was then acquired by Alight in July of 2018, and then went on to found A Healthcare Z, which is where I know him most from, where Dr. Bricker provides about 400 healthcare finance educational videos, and sees over about 220,000 views per month. Actually just watched his one that came out this morning. If it arrived in your email address, your emails as well. He also sits as the medical director for Coop Health and Simple Pay Health, which are alternative health plans for self-funded employers as well. So again, two people much smarter than me that will serve as our experts today around this topic. And really what we're going to focus on today, and you can see from the title, Hype versus Value, specifically around chronic conditions, but really across the whole kind of benefits landscape. How do we really drive values for health plans? And I know it says employer, but really any health plan, whether it be a carrier, a payer. We also see this even in health systems themselves across their employee plans, but then also their value-based plans. How do we take all of the myriad of solutions that are out there and figure out how do we actually deliver value, drive value, especially in what's becoming an increasingly muddy world. And I said we won't spend a lot of time on slides, but I do want to focus on one, and then I'll actually take the thing down. This is what I like to call the preaching the choir slide. This is something everybody knows. Chronic conditions, especially those cardiometabolic conditions, hypertension, high cholesterol, obesity. Most people that have them, actually 1 in 3 have at least one of these conditions. Very, very few people manage them well. We know that, and that's something that's been a challenge for a good long time. And a huge amount of spending in all of our health plans is driven towards or derived from these conditions and the exacerbation of these conditions. And as a result, there have been over 400, and that's probably growing every day, different kind of point solutions that have been designed to attack this specific problem. And the problem, and what leads to our discussion today, is that they really haven't been able to show much as far as moving the needle. So that's kind of to set the stage for the conversation today. I guess I want to start off, and I'll put this to both of you, but Kenny, I'll start with you. I guess first, let's take a step back from the solutions and all the things that have been thrown at this problem. I guess I'll start with kind of the kind of unfair question, but why is it still a problem? I mean, I know that, and this is I feel a little odd asking you guys both this question as both internal, and primary care physicians, but these are conditions that have largely been relegated to primary care. So I guess I would say it nicer than this, but why do we as a population, never mind where it's coming from, struggle so much with managing these conditions?
It's both multifactorial and multifaceted, Dan, but and I'll try to constrain myself in the answer because I could go on for a really long time. But suffice it to say, like I did practice primary care full time, for about 15 years, where I cared for a panel of about 4,000 patients. And I can honestly say the three words that I said more often in all of those 15 years than any other three words were, "I'm so sorry." And I remember it so clearly because it was, "I'm so sorry I'm running late. I'm so sorry I couldn't get you in to see you the other day. I'm so sorry I'm calling you on the weekend with test results. I'm so sorry, my partner had to take care of you, the last time." All of these types of things, right? So so that sort of boils down into two main issues. One, there's not enough hours in the day. If you look at these studies from 20 years ago from two guys, one named Osby and another was Yarnall. Osby found that it would take about 10.6 hours per day for a primary care physician to manage all of the chronic conditions for a panel of 2,500 patients. Yarnall further reinforced that with it would take 7.4 hours per day to manage that same size panels, all of the guideline directed like preventive health and health maintenance, and all of those things, which presumably would leave the remaining 6 hours of the day to actually like take care of the sick patients. And so literally primary care has evolved to become mission impossible. A study from 2 years ago actually further elaborated on all of that, saying, okay, how many hours would it take to do everything that a primary care doc has to do? They used statistical modeling, and it turned out it would take 26.7 hours per day for a primary care doc to manage all of the care that a panel of 2,500 patients would need. And so it's just not possible. Now, interestingly, that same study that used analytical modeling actually leveraged a team-based, support model, where it's like, okay, if all of a sudden now you had a team helping to support primary care and you align the knowledge and the skill with the task that needs to be completed, how many hours would it take per day? And the answer came back 9.3 hours per day with a team-based primary care model. So the key is, how do we transform primary care to become more of a team-based model? But what are the economic models that allow us to do that? We have to get creative with the way we finance and think about it, because the standard fee-for-service reimbursement of transaction-based primary care is not enough to pay for a team. And so part of this is we have to then get very creative, but we know that when you do leverage this team-based model and you figure out how to deploy these resources through an economic lens, you can now actually, get all of the work done. And then the very last thing I'll say is this, which is the other issue with, and this is all of medicine, not just primary care, the volume of medical knowledge would double about every 50 years as of like 1950. And as of 2020, the volume of medical knowledge doubles every 73 days. There are literally tens of thousands of citations and studies that are published every year. It's literally impossible for even the smartest of us clinicians to stay completely up to date. And so we have to figure out ways of taking knowledge that has been really elucidated and can be codified into algorithms or protocols, and then capture that in a way that you can then deploy the application of that knowledge in a scalable, repeatable manner.
Gotcha. So it you got the thumbs up so far, but I guess the gist of that is really comes down to time, right? So and in talking to our own primary care providers, there's always been, it always comes down to two things. It's time and information, right? So I guess, first of all, Dr. Bricker, anything to add to what Kenny had, but then also the other side of this is there's teams which you can give support staff, you can give support technologies, which we'll focus a little bit on today. But there's also, and correct me if I'm wrong, we all foresaw provider shortages, but probably nothing like we're seeing right now. But how does that factor into our ability as a population to manage this?
Yeah. And I mean, what Dr. Cole said was so good. I could just like sit here and listen. my role is to just sit here and listen to Dr. Cole like everybody else. I will just add to that when we talk about cardiometabolic illness, like we're talking about diabetes and hypertension and high cholesterol that ultimately leads to things like heart attack and stroke and peripheral vascular disease that can lead to like non-healing ulcers and like you're needing amputations. It's the leading cause of blindness in America. And actually, it's associated with something that's called hyperinsulinemia as well. So we got it. We got two doctors. We got to do a little doctor talk here. And so those high levels of insulin, when you have quote unquote cardiometabolic disease or metabolic syndrome, actually increases your risk for cancer. So it's actually it increases your risk for breast cancer and colon cancer and a whole bunch of other types of cancer too. So it's actually a carcinogen. Okay. So where's all that coming from? It's coming from our food. And so it's really our diet. So you got to understand, I'm not going to spend a ton of time on this, but for anyone who wants to research it more, there's a guy named Dr. Robert Lustig out at UCSF that's really the expert on this. But really, our food supply is like a jungle, okay? In that it is, to a certain extent, it's dangerous, okay? All the sugar in our diet is frankly dangerous, and it's dangerous to our liver. And it's actually our liver dysfunction that then causes all of these cardiometabolic problems. So we've got pythons and jaguars and piranhas in our food. And what Dr. Cole was talking about is that for almost anybody, it's almost impossible to like navigate the Amazon jungle. Like I wouldn't survive more than a couple of hours, right? I'd get eaten. Okay. So you need to have a guide. You need to have an expert who understands how to keep you healthy in that jungle. And that expert is the multidisciplinary team that Dr. Cole described. And to Dr. Cole's point, and to your point, Dan, in order for that guide, in order for that clinician, and when I say clinician, it's a combination of the doctor, the nutritionist, dietitian. It could be a mental health professional as well. There's all sorts of people in this team that are going to help you to be healthy in this jungle of disease producing food. And in order for those folks to effectively work with patients, they need, to your point, time. And that time is necessary for the behavior change. So in other words, if you see a bunch of piranhas swimming in the water, don't jump into the water there. You got to change your behavior. Okay. And behavior change. Now you could say, well, we got to clean up the Amazon jungle. I mean, that's fine. We can work through, politics and all sorts of stuff to like decrease sugary sodas, yada, yada, yada. Okay. But in the meantime, we've got to have a change of behavior fostered by the multidisciplinary team that you, Dan, and Dr. Cole are talking about. And to your specific point, Dan, around the shortage of clinicians, well, shoot, if you don't have enough guides and you've got hundreds of millions of people in the Amazon who are struggling, then you got a problem, right? So at a very basic level, you need to just have enough guides to foster the behavior change. And so we'll talk about how we can like leverage technology, et cetera, to sort of fix that problem. But that's how I would begin the conversation.
And I,
I,
and I want to
like the analogy. I would say, chocolate.
Yep. And I'm sorry, you're muffled a little bit too, Dan. At least you were
Yeah,
for
Dan,
me.
your mic for some reason is not working anymore.
Yeah, but while you're working on that, like yeah, I had two things I wanted to add. One is to respond to a question in the chat there. I must have miscommunicated. I apologize for that because I think that it was construed that I was saying it's not economically viable in terms of not being able to reduce total cost of care. That's not at all what I was saying. What I was saying is that the current financing mechanisms or the mechanisms of reimbursement do not pay adequately for team-based care. So for example, in a Medicare Advantage model where we can take full risk for the total cost of care, and our economic model is a risk-adjusted population-based payment, and then our expenses are our operating expenses and the medical expenditures, now you can devise an economic model that allows you to capture margin by keeping people healthy, keeping them out of the hospital. The commercial financing mechanisms for primary care are still predominantly fee-for-service mechanisms that would never cover team-based care models. That's what I was trying to say. And then the second thing I'd like to add, and this kind of picks up on what Eric was talking about. So I was born and raised in South Louisiana, where life is governed by the 5 F's, faith, family, friendship, food, and football. And to sort of carry on with what Eric was saying, I look at this as a football analogy, and essentially the offense is a team, a multidisciplinary team, where the most important member of the team is the patient, because the patient has the football. And the patient is trying to get down the field in order to achieve their health-related goals or attain their optimal state of health. The defense that the patient has to combat against is multifactorial, right? It is the burden of chronic disease, often overlapping multiple different chronic diseases, sometimes impaired mental health determinants, sometimes impaired social determinants of health, unhealthy behaviors, maladaptive coping mechanisms. There are lots of reasons why people either choose to eat what they eat, when they eat, how much they eat, when they're engaging in unhealthy behaviors, at things like adverse childhood traumatic experiences. There's a multitude of defenders there that would be tacklers that would prevent us being able to make progress toward that health improvement journey. And it takes this multidisciplinary team in a highly coordinated manner, leveraging the right types of tools and technologies to be able to overcome all of those barriers in order to achieve that success of a health improvement drive, if you will.
And I actually, I'd seen that question as well. I said we probably should address that one. So thanks for jumping in on that, Dr. Cole. I guess, now to make it a little bit more solutions focused, obviously, whenever there's a problem, people will throw solutions at it. So I guess if it's, not that it's not nuanced, there's a lot of factors to it, multifactorial, as Kenny said. But there have been just so many solutions emerging. So why are we seeing such a variation and such a multitude of people trying to attack this problem so many different ways? Is it, I understand it's complex, but at the end of the day, it's managing a few conditions that have been well known for decades or even centuries when you look at it. So why are there so many people jumping into this space? I'll start with you, Dr. Berger.
Oh, okay. So interestingly, I would say that the reason there are so many point solutions is because it actually mirrors, frankly, one of the shortcomings of the medical establishment ourselves, which is an overemphasis on subspecialization. So when I was in my residency at Johns Hopkins, the chairman of the Department of Medicine said, subspecialization is a sign of maturity. And I was like, wow, wait a minute. I'm not infatuated with the heart or the lungs or the kidneys. I like the whole person. I like to treat people, not specific organs. And so all of medicine has become incredibly balkanized. And that balkanization has then translated into the point solutions. And I think now I'm an eternal optimist. I think the pendulum is swinging. I'm not against specialists at all. The point is you can't do too much. It's like the Goldilocks. You can't be too hot. You can't be too cold. You got to be in the middle. And so you can't have over specialization. You can't have under specialization. I don't think anybody here is trying to say that a multidisciplinary primary care team will be able to fix every health problem. Of course, that's not true. But the point is that there's a balance, and it's swung too far in the direction of uncoordinated, oftentimes conflicting specialization vis-a-vis the correct balance, which frankly is a balance. It's one of the reasons why I'm here today. It's one of the reasons I think Ochsner achieves that balance. I think they're the perfect folks through their experience in Louisiana and the Gulf Coast to make that balance happen.
Appreciate it. I did not prompt that, but sorry, go ahead, Kenny.
Oh, I'm sorry. I was going to say what I would add to that is that, the medical students choosing specialty related fields, in part, that also reflects the flawed financing mechanisms that are approached, right? Because what we pay for in healthcare is not for keeping people healthy. We pay for imaging, procedures, surgeries, which oftentimes are done by procedural subspecialists. which then leads to more lucrative, incomes for those specialists, which then sort of further, when primary care, life on that hamster wheel of a treadmill of primary care becomes miserable, you get fewer people choosing primary care, more going into the lucrative, rewarding specialty care. That's part of it. And then the other part of it, though, is I like to distinguish between traditional health systems and systems that deliver health. And I think traditional health systems, they are very similar to IBM from the early 1990s, where IBM made a bunch of expensive mainframes, and they really were, all of their profit margin were on all of these expensive services like these big mainframes. And so when the little things like, personal computers and desktop computing, and all of these point solutions emerged in the world of computing, IBM initially wasn't focusing on all that kind of stuff. And there are a lot of other people within the market, they had to develop their own like point solutions to meet needs that the customers had. But fortunately, under the extraordinary leadership of a man named Lou Gerstner, IBM actually transformed themselves and actually became very good at delivering a lot of those solutions themselves. Thus, they never abandoned their mainframe business, but they got really good at delivering solutions and services to their customers. And so to me, that mirrors the evolution of a traditional health system to a system that delivers health. Is traditional health systems have got to move away from their core, business just being all of the rich procedural and times overpriced, procedural services, and diversify in a way that not only still delivers those services that are needed at a tertiary level, but also developing their own solutions that meet the needs of customers and patients, that we've got to do this ourselves.
Makes it, and again, well, that's the value of kind of the providers of care versus, again, multiple point solutions. So I guess we'll kind of pivot a little bit to our topic today. I think we set the stage pretty well. I guess with all of these solutions from various different, etymologies coming to market, kind of we've seen, frankly, not the best reviews. I mean, if you look at the Peterson Health Institute report on diabetes solutions, basically came out and said, monitoring is not the answer. I mean, it's basically they said there's really very little value to simply monitoring, which I guess you understand the logic of it. If people are aware of their condition more, they'll take more action on it, but it hasn't really driven to the outcomes we're looking for. There was a National Institute of Health study done last year that looked at about 300 or so different point solutions and found that over half of them couldn't show any sort of clinical value whatsoever. So I guess I'll start with you, Dr. Bricker, because you're more external and actually see a lot more of these vendors. I guess, where have these point solutions kind of promised versus fallen short?
Yeah. So kind of to Dr. Cole's point, kind of like the Watergate thing, follow the money. Okay. And so in order for these point solutions to get started, they got to go out and they got to raise money from venture capitalists. And what do venture capitalists are like? They're like, how does this scale? It's got to be a huge solution. And so by definition, from the beginning, all these point solutions are like, we need to be able to scale. And by scaling, that typically means like through software, through technology, whether it be an app, blah, a device, blah, blah, blah. And so then by definition, you typically have technologists, software programmers, et cetera, that are starting these businesses. Well, shoot, those people haven't literally taken care of patients and seen the complex struggle and relationship-based solutions that are necessary. So fine. So you create all this stuff that scales, all this technology that scales, but the problem is because they don't understand the patient care aspect, then it doesn't work. It's like going out and saying like, hey, I've got this amazing app that teleports people. Oh, I'll invest in your teleportation app, right? That sounds awesome. The market for teleportation apps is huge, right? Here's the problem. Teleportation apps don't work. You can't click on a button and just show up somewhere, okay? And what we have created is a bunch of point solution teleportation apps. And you can make it sound good. Well, we're going to take your molecules and we're going to put them on the internet, and then we're going to reassemble them somewhere else. And you can have all these like typical reasons for why your teleportation app sounds good, but it doesn't work. And so that's what we've ended up with. And this is where the key with all healthcare stuff is you got to begin with the patient in mind. I mean, it's what Dr. Cole was told. It was what I was told, is you put the patient first. You start with the patient and then you work backwards to the technology. And oh, by the way, this entire model is not designed to satisfy the spreadsheet of a venture capitalist. So in other words, your goal is to actually transport the person safely and actually make it effective. Actually, it actually causes them to have their cardiometabolic health improved. And then you work backwards into, okay, let's do that for one person. Let's do that for 10 people. Let's do it for 100 people. Let's do it for 1,000 people. And so you work backwards then into how to apply it to more people. And I'll pause there.
Now, I think I'm a little biased on that one because that's obviously as a health system the approach that we've taken. I guess, Kenny, to add to that from a clinical perspective, you look at a lot of the things where the market are around, technological engagement. To Dr. Bricker's point, it's the fancy app, which is necessary. You need to have engagement. You need to get people involved, and you need to get them activated. But I guess what's the difference between simply just getting that engagement or be able to coach or feed content versus an actual, the actual clinical management of a condition? And I guess, how do you marry those two?
Yeah, so I think there's a couple of things. Yeah, I think a lot of the stuff that's out there in the market today is really more on the monitoring side and not as much on the management side. And so, the monitoring programs that are out there are predicated on the idea that when you give a patient insight into whatever their blood sugar may be or so their blood pressure or so forth, that they will then change behaviors, even and there'll probably be some embedded types of coaching and things like that. The problem is that first it underestimates or it does not identify all of the variables that may underlie the reasons why a person may or may not change behaviors, right? So a person may not change behaviors if their entire life, the way they've coped with stress is through food. Well, it's going to be really hard for them to change their diet if the entire way they know how to manage their stress is through food, right? So that then needs to deploy a different type of coaching or behavioral therapeutic intervention in order to be able to foster that sort of behavioral change. So that's one piece, is how to change human behavior and understanding all of the obstacles, barriers, and challenges that stand in the way of human behavior changing. The second is the actual application of medical knowledge to problem solving. So what I mean by this is that, part of the I talked about how it's impossible for clinicians to stay up to date. Like, this is nothing new here. Unfortunately, it takes on average, studies continue to show this, it takes on average about 17 years before a study that finds a benefit of a new medication or something like that to actually get translated in a scalable way across practice, right? Like we know that, these certain drugs, a family of drugs called ACE inhibitors, like they hit the market, and their impact on heart failure was huge because they reduced the afterload that the heart had to pump against, and they had this huge mortality benefit. Well, it was 17 years before ACE inhibitors routinely incorporated in the treatment of heart failure. So the management piece of this becomes incredibly important because the science of how we would manage both hypertension and diabetes is constantly evolving and changing. And again, because it's so hard to get all of the doctors on the same page in terms of what's the most up-to-date evidence-based way of managing these conditions, when you, in a more centralized way, create these care pathways and clinical protocols, and you're constantly tweaking them and refining them based on the newest evidence, because what you have is someone whose sole job is to stay up to date with the evidence and then make sure that those protocols are quickly updated. All of a sudden now you can ensure that you're applying more evidence-based, guideline-directed care at the point of care in a scalable way, because you're changing the mechanism of deployment, and it becomes about remote patient management instead of just remote patient monitoring.
Thanks for that. So I guess now we'll get to a little bit of the meat of some of the questions that we're even kind of seeing. So a lot of people that you guys are talking to today, it's a pretty wide mix, but if we kind of overgeneralize, we've got a lot of in the benefits consultant world, that are trying to steer their clients, whether it be employers, and to say, okay, well, how do I find the solutions to meet this need, right? And frankly, been struggling with it now for years. You've got some benefits professionals at large employers that are saying, how do I fix this problem? We've got some medical directors and some product folks from payers and carriers. They're saying, how do I incorporate the right thing into my plan to impact the population health of my folks and candidly improve my star ratings and my outcomes and things like that as well. And frankly, even a couple other health systems that fortunately are kind of forward thinking, saying, hey, if it's working for Ochsner, how do we make it work for them, right? So that's kind of the audience today. So if I'm one of those folks and I'm just getting bombarded, and I'm sure you guys do, and I do, I'm getting bombarded by multiple solutions. To your point, Dr. Bricker, backed by, I jokingly say, monopoly money worth of marketing dollars when you're talking the VC world. How do I parse through it? What do I look for in some of these solutions to say, this is actually going to do what it needs to do? I'm not just seeing a slick app or a slick marketing campaign. And I'll open that to whoever jumps in first.
Okay. I'll jump in. Okay. So the one of the keys to behavior change that Dr. Cole's talking about is customization, because every person is unique. And so that's why the technology doesn't work, because it doesn't customize it to the individual, because everybody is very unique in terms of how they need to change to improve their health. Okay. Likewise is true at the employer population level as well. So not all employer populations are the same. And so you need to think about, okay, well, what are the factors of the employee population that then determine the approach to use to address that cardiometabolic health issue? Okay, there's a few big ones to keep in mind. One is obviously the age of the employees. So number one, older populations have bigger problems with this. The types of industries that have older populations are municipalities, education, school systems, manufacturing, trucking, transportation, et cetera. Utilities, energy companies, et cetera. Okay. What companies are not like this? Technology companies. You've probably heard me say this before. The average age of an employee at Meta, Facebook, is 28. Okay. They really don't have a lot of cardiometabolic problems at Facebook. They don't. They're just too young for it. Okay. So one is the age of the population. Two, this is a huge one, the turnover of the employee population, because we said that this takes time and it takes a relationship. Well, if you have employees and plan members who are constantly coming and going off the plan, then any sort of relationship-based solution is frankly probably not going to work for you. Okay, so what is the classic high turnover business? Is convenience stores. Okay, like I know a huge national convenience store chain. Their turnover is 80% per year. 80%. There's no way you're going to be able to have a relationship-based cardiometabolic solution work for them. However, what are the industries that have very low turnover? Interestingly, it's the industries that have very old employees, right? So municipalities have very low turnover. School systems and education have very low turnover. So you really want to focus on a lot of manufacturing has low turnover. There's a lot of these lifers that work for like Atmos Energy and all these utilities as well that have been there for 30, 35 years. Okay, so that turnover is hugely important as well in terms of matching that. Okay, now the next thing that you're going to want to have in terms, so there's other factors as well, but you're going to then diagnose that, and then you're going to then look at your universe of vendors and say, where have they demonstrated a proven track record of relationship-based solutions? That's it. That's how you do it. And then the number one thing you do to establish a relationship is you have to actually establish the relationship. In other words, you have to talk to them. So has the organization actually been able to get people to talk to them? Notice I specifically am using the word talk. I'm not using the word engagement, because it is not via text, chat, it's not that. It's actually a conversation, because we all know that 80% of communication is actually not in the words that we use, but it's in our nonverbal communication. It's in the tone of our voice, the speed of our voice, our facial expressions, our mannerisms, etc. So that is the beginning of how you would go about matching the employee population with the solution that's the right fit for it.
So I guess my question there is, and obviously it's the engagement side of it, but Kenny, I'll kind of put this one to you because I think that tracks everything with what Dr. Bricker was saying. I guess at what point though, engagement is step one, and I agree, talking is important, and you have to meet people where they are. So I think it has to be a mix of communication models, right? I mean, but at some point, someone has to have a conversation with someone, or a relationship is not built. I think that's perfectly fair. But how do you know that it actually works? I guess that's the question. Like you've talked to them, right? And yeah, I think every solution out there has a paper or a study or something that they've commissioned that they can point to. But I'll put the same question saying, I'm one of these people that has a population I need to impact. What outcomes am I looking for? Is it engagement? The number of people I've been able to talk to? Is it, I guess when I go to one of these vendors and say, can you show me that you've done something? What is the something?
Yeah. And so, in my own journey, I'll tell you, when I first left private practice, I did something that I never in a million years imagined I would have done. But it was valuable experience. I actually worked for a payer for a year. I worked for a commercial insurance company, and that payer, had a huge, division called care management. And the measure of success in that care management department was if the care manager called one of their members and the member answered the phone. And that was chalked up as a success. That was a successful outcome of care management as administered by a payer. And so, I don't think that is what defines success. I think what defines success is measuring and holding yourselves accountable for the health outcomes that you're delivering. And so what I would then say for us is, or for any system that wants to try to do this for their patients, it's okay, how effective are my solutions? How effective are they at controlling, a patient's blood pressure or a patient's blood sugar or their lipids? And now not only holding yourself accountable for the percentage rate of control that you're achieving across these various conditions, but also looking at other numbers like how often are they going to the emergency room? How often are they getting admitted to the hospital? Since we know that healthcare, unfortunately, is ripe with tons of disparities and inequities, other questions that can be asked is, are our solutions equitable? And, do we achieve the same results and the same outcomes regardless of socioeconomic status or, regardless of traditional healthcare disparities? And so looking at it with a lens that's focused on actual health outcomes, and then looking at those outcomes and constantly being able, through iterative and recursive loops of continuous improvement, asking yourself, like I'm at a point now where like anything less than a 90-something% rate of like hypertension control or even diabetes control seems kind of like poor to me. But the reality is that most traditional health systems, they probably have like 60% rates of, hypertension control or diabetes control. And that's because they've never engaged in these iterative and recursive loops of like, what's possible? What if we tweak this? And then what if we adjust this? And, like that's the key, is these loops of continuous improvement based on the outcomes that you're achieving.
I think that so again, I'm putting myself back in that person's shoes, and that's for the folks that are listening today. Okay, so I go out and I find all these different, if I find the right solutions, right? And I think your former world, Dr. Bricker, and mine, and some of the other kind of navigation vendors out there certainly help with that. But I think we've seen over time almost kind of a pendulum swinging. If you go back, it's especially in the benefits and carrier world, where, well, I got too many solutions, so I'm going to go with somebody that does integrated solutions, right? And so it's people that do a lot of stuff. And the challenge there is, then over time, you find that they do a lot of stuff, but to be cliche, they're the jack of all trades, master of none. I'm not seeing the outcomes I'm looking for. So let me start looking best in class. We're going to swing the pendulum over this way. and I've got a bunch of different solutions that might drive, but I can't get the engagement because it's too many solutions and it's the solution fatigue. So now we're kind of coming back the other way, but the answer there is, well, let me look for, pardon me, like the easy button. Let me look at these vendor ecosystems, because many of kind of the mega vendors or the carriers, et cetera, are building these kind of ecosystems where they have their vendor for these, so the different types of vendors, and you can kind of just buy into or kind of click into one particular vendor ecosystem. I guess, we're a little biased in this one. So Dr. Becker, I'll put to you, what's the challenges with that? So if I'm one of these people again, and I'm looking at now aggregations around vendor ecosystems, how do I start to choose what's the best one there, or pick those apart and say, well, is that really the right solution for me? I'm just trying to get in the mind of some of the folks that are listening to us today.
Yeah. So it's a great point. Again, I would argue it really comes down to customization. And so I become very wary of uncustomized solutions or things that are prepackaged. And again, it's a balance. It's Goldilocks, right? The more you want to press the easy button, the less customized it is going to be. And then the less you press the easy button, in other words, the more work you have to do, then the more customized the solution is going to be. And frankly, it's probably going to work better for your organization. And so that's just a personal question that everybody, and maybe the right answer is in the middle. The right answer is not, tons of time, but I will tell you that the high performing employee benefits teams are frankly rather large, and they are filled with very capable people. Okay. So so the number one example of that is Walmart. Okay. The Walmart employee benefits department is huge, and it's filled with, guess what? Ex-brokers and consultants, right? So they hired the people who actually work at Walmart, who used to be in your shoes if you're a broker consultant, but they work for Walmart now. And I've had lots of calls with the Walmart people. The people are smart. Okay. They understand healthcare completely. So there's a lot of times where it's like the person kind of came from comp or from payroll, and God bless them, they're trying, but they didn't kind of grow up in a healthcare world, right? And they're trying. I know the head of benefits for a huge microchip company was doing Asia compensation for the last 10 years and just moved back to America and is now running benefits in the United States for this chip company. Yeah, good luck. I wanted to give her my phone number. I'm like, let's talk, because I got a gazillion things that I need to teach you after being in Taiwan for the last 10 years. Okay. So that's one. And then two is they're pretty, and the other example I use there is that the teams are pretty large. Like at Purdue University, they got 30 people on their benefits team. Okay. So I understand that not everybody has, the budget and the staff to, that's why you kind of have to Goldilocks it. But just know the more you push the easy button, the less likely it is it's going to work.
And yeah, Dr. Cole, I guess the last thing, then we'll start answering some questions. We've got a couple that have popped in. What is the role? And a lot of these point solutions are trying to fill, going back, almost the void that's in traditional care, right? So like we said, traditional care is not necessarily meeting the need. So all these point solutions are jumping in and nature reports a vacuum. I guess now, how does a health system, so a hospital system, evolve, or what's the role of the hospital system to start to, since we're seeing the point solutions aren't doing it, how does the hospital system fill the void and eliminate the void?
Yeah, I want to go back for that. I want to go back to the story of IBM, because it really is a powerful story. And so what was happening at the time, what was happening in the 1990s was there were tons of point solutions that were all being deployed within the market to try to meet voids that were not being met by a traditional kind of computer, manufacturer. And the CEO, Lou Gerstner, when he took over, what he realized that, he just looked back at all of his previous roles as a CEO and his own decisions of how to buy technology, which technology to buy, like all of those types of things. And what he realized was that every system, really what they need is an integrator. They need somebody who's going to kind of bring this together in a comprehensive way of understanding. And so he just looked at it through the lens of what would I need for my own company? And I wouldn't want to have to go and buy a bunch of different point solutions. I would want to be able to go to one trusted vendor and then basically let them, sort of tell me what my, problems, issues, needs are, and what solutions can they then help me, to build out. And that's how they kind of developed they sort of morphed and transformed into more of a solutions and services provider. Now, let's translate that. Let's look the lens on a health system. So for us, same thing. Like Ochsner actually happens to be the largest employer in the state of Louisiana with over 35,000, members of the employee health plan. And so the problems of an employee health plan, I mean, look, we know that firsthand from being an employer. And so just like any other, large employer, we're going to struggle with, lots of different types of members, some of them who are very expensive. Chronic conditions are going to account for 85% of all of the medical expenses. And so how do we develop a solution for this? And so that's sort of the origin of how this came about. And then again, it's sort of the same thing. Like, okay, now is the solution actually translating into improvements? Is it translating into decreased total cost? And if not, how do we need to tweak it or modify it or adjust it in order for it to do it? And so instead of it being sort of a narrow slice of the market, because that's what a venture capital backed company is going to do. They're going to look for pain points within an industry. They're going to look for this narrow slice that they can kind of zero in on and try to deliver, a great solution for this narrow slice. The problem and the challenge is that there's so many of those areas that you would need a bunch of different point solutions. And so a health system can be an integrator and because they are an employer, so that's one. And then quite frankly, health systems need to figure out how to transform their own business models, because as long as their business models are contingent upon doing nothing but taking care of the downstream problems through expensive surgeries and procedures, they will be rendered increasingly irrelevant if they don't figure out how to manage the upstream stuff as well. And so for health systems, it's both being an integrator as an employer, but it's also how do we transform our own business model so that we can stay relevant and not get disrupted, and be the force that actually transforms healthcare. Because that's what, of all, you can look at success stories, like you can look at even some of the people that I admire the most. There was a company called Iora Health that was phenomenal at improving outcomes. But I know the CEO and founder of that company well. And the last time I spoke with him, he was like, yeah, Kenny, like we did some really good things and we did improve the health of a lot of people. But in the end, did we transform healthcare? And the answer was no. And I think the only way that we're going to transform healthcare is if the health systems figure out how to lead the way. And so that's another big piece of this as well.
Dr. Berger, anything to add? If not, we'll start taking some questions. You're on mute, sir.
No, nothing to add. If you want to get to questions or go on, Dan, I'll give the floor back to you.
So yeah, I guess there's a few here. I guess one, some I think is a little bit familiar with what we do, regionally, but the one question here from I think it's from a benefits consultant saying, that they love the idea of a direct contract, or direct contracting with local health systems, right? Because some of them have some of these solutions they can offer locally. Challenge being that becomes very regionalized for some national companies. So now I'm a little biased on that one. We actually are licensed in all 50 states, but I guess, I'll ask you, Kenny, because I know we do some things locally. How do you look for solutions that have those clinical outcomes? How do you work with a health system to find solutions that can impact a broader population?
So I think that basically, again, same type of thing. Like we're struggling with all these challenges ourselves, right? And so if a solution that a health system deploys is not actually translating into improvements in health outcomes that then correlate with reduced medical expenditures, then there's no margin to be captured on the solutions that you are developing, right? Like, so think about it with a lot of venture capital backed entities. I mean, they're just interested in a return on investment and, potentially could they sell it, make a profit, all these types of things. For a health system, it's really different in that it is, one, are the solutions effective? Because if they're not effective, then we're not going to continue to deploy lots of dollars. You know, with health systems eking out 1 or 2% margins, you're not going to be, you know, spending tons of your 1 to 2% margin on a solution that's not going to translate into a return on investment. The second is that you're not necessarily trying to, you know, create a solution that that enriches the founders. What you're really trying to do is look for a solution that allows you to remain economically viable. And how do you translate that economic viability of reducing medical expenditures into one that basically aligns better clinical outcomes, better health outcomes, because in the end, that's the mission of a health system, with better financial outcomes. And it's just that, unfortunately for health systems, that has not been the way things have been previously for health systems, right? And in fact, there's a saying called "no margin, no mission," which has been used to justify the only way we're ever going to have a margin to carry out our need is we've got to, generate a margin on all of our procedural stuff. And so the focus is on building out all the stuff that generates the dollars through procedures, imaging, and all these downstream things. That fortunately is changing. And so hopefully that answers the question. Let me know if I can clarify.
I guess another question here says, what about, again, another challenge with multiple solutions and external solutions is how important is it to incorporate in the primary care provider? So, and I'll start with you, Dr. Bricker, and then I'll open up to Kenny. So again, we talk about team-based care. These solutions are often doing a part of that care, whether to various degrees. How important is it that you close that loop back to that primary care provider?
Yeah, so that's a great question. And again, as is the case with healthcare, short answer is it depends. So, and we had firsthand experience with this at Compass. And so you got to understand that for an employee population, that the majority of the employee population, upwards of 2/3, have not seen a primary care physician in the prior 2 years. So number one, it should actually be assumed that the person does not have a primary care physician until proven otherwise, because they most likely don't. And there's parts of America where it's much worse than that. Okay, so like they oftentimes they don't have one, and so essentially part of what the solution can do is actually connect them to a primary care physician. That's actually part of the methodology. That's one. And then two is, to Dr. Cole's point earlier about how, listen, a lot of these primary care physicians are still working on fee for service. So you're talking 8 minutes of face-to-face time, 15 minutes for the visit total, because they're spending 7 minutes on the electronic medical record, typing in the note, blah, blah, blah. So only 8 minutes of face-to-face time, 7 minutes, so it's 15 minutes. So they're seeing 4 patients an hour. The doctor the primary care doctor in a fee-for-service system does not have time to do the types of things that are necessary. And so frankly, they need Ochsner's connected health solution to do this, because they don't have the time to do it, and they're not going to do it. You're not stepping on their toes. Oh, that's what I'm supposed to be doing that. Like 99% of the time, that was not our experience. Our experience with the primary care doctor, oh, I'm so glad you're doing this, because frankly, I don't have time to do this. And I'll pass it over to Kenny.
Well, actually, before Kenny shows, because it's something we get often when we talk about our solutions. So, and we very intentionally didn't focus on that a lot today, but we offer a primary care, we offer a cardiometabolic solution nationwide that is driven by obviously an academic health system, and it's actually focused on management, being ability to manage medications, and we do offer it across the country. And one of the questions we get from consultants and from our benefits and from our carrier partners really, really often is, hey, aren't you really going to tick off the primary care provider? Well, one, we do bring them in the loop. So we tell them what we're doing and we give them information. But the reality is, the vast majority of the time, and I mean, I can count on one hand how many complaints we get from providers, because at the end of the day, if that patient comes into them and their blood pressure is good and their diabetes seems it's under control, check, awesome, I can move on to other things. I'm glad you're doing that, right? So, but it is, I'm glad you said it, because it is actually a question we get very often when we talk about what we do nationwide as well. Kenny?
Yeah, and I would say, I mentioned earlier that, when I was in full-time private practice and I had a panel of about 4,000 patients, like literally it was mathematically impossible for me to see every single member that was attributed to me, like as often as I needed to see them. It wasn't even close. And I remember in particular, this one patient who, I guess I would give like I'd give refills of a blood pressure medicine. And it struck me and hit me at one point because if you had asked me like when was the last time I'd seen this patient, I probably would have said, oh, it's been within the last year. And I'll never forget this one patient when I look back and I had been refilling this person's blood pressure medicine for like over 2 years. I think it was 3 years that I had been doing it. Now, that was almost malpractice, quite frankly, because the patient should have been having monitoring labs during that time. That wasn't happening. It wasn't done maliciously or it was just done because like I didn't realize. I had no concept that it had been 3 years since I had actually last seen this guy, done blood work, so part of it is understanding the plight of primary care, which I lived on that treadmill and I understand that plight well. And so in this case, it would be a wonderful thing to have like, hey, you know what? It's been a year since you've last seen this person, or it's been 6 months since this last seen this person. It's been 6 months since the last, BMP, basic metabolic panel, which is a blood test we do for monitoring, and to be able to then direct to the primary care doc, because that's what will happen is if a problem arises that, or if the patient's just been a long time, then the guidance that patient's going to get is, hey, it's time to go see your primary care doctor. And so the solution doesn't actually decrease the interactions with primary care. If anything, it probably increases or at least keeps them the same because you're getting that guidance of, hey, it's been too long, time to go back. Yeah.
Excellent. So I'm just gonna, as I know we are coming up on time, so I'm gonna throw this up there. I know there's a couple questions we didn't get to. There's been a couple comments also kind of asserting the same things you guys have been saying. So kind of agreeing with you as well around the lack of preventive care, questions around the need of that support team. So I did throw this up. There's a QR code here. We'd actually bring it to a form if you have any questions. There's also our Vice President of Sales, Bob Kelly, there's contact information there. We will also be sending this out to everyone who's registered also. But I know we are coming up on time, so I wanted to be aware of that. So I just want to thank everyone for taking some time today. Dr. Bricker, Dr. Cole, a great conversation. I appreciate you guys giving us a little bit of your time today. And we will obviously send out follow-up. And if there's anything that makes sense for us to connect to you guys or follow up with you, I will certainly reach out. Thanks everyone for the time today.
Thanks, everybody.
Thank you.